And then I'm going to share with you my Moodle page just to show you guys. I changed. Now I can't find my share button. There it is. Okay. Oh, hold on just a second. Okay, so I just put in the Zoom link again in the general section. If you guys can, hopefully you can see this. I put it down here. So this is where you have to cut and paste it into the search bar, but I just put it again below it, but in a clickable link. So you should just be able to click there to get in. So hopefully that's easier. Just a reminder, here's that Google Doc. I did see somebody posted something in it the other day. So I try and check it every couple days. So use it if you have questions. You can always email me too. I mean, there's lots of different ways, but that's just kind of a living doc to see what questions have come in from other people. And then I put in this office hours. So I posted a Zoom office hours for tomorrow at noon, and I just sent you guys all an invite. I realize some of you may not be able to make it, but if you are and you have questions, please feel free to come. I'm just going to be working at my desk, so it's nothing structured. It's just simply a time to ask questions. Next week is the exam, and it's over today's material, and then weeks 1 and 2. So if you have questions about, something to clarify something from this week or from previous weeks, it's just Q&A. It's just some extra time. So I've tried to put, I'll open this.
Hey, Leslie, what time was that on though?
It's at noon tomorrow.
So my question is, we're all working on our student partners. What time do we go? Are we done at that time?
I don't think so, because we swap who's patient and who's clinician.
Like what time? Yeah, what time does the first group end?
I think 12 to 1:30 is the lunch break, so we should
okay.
be during this time.
So I just want to say that it is snowing right now, and I'm excited about it. That's
Leslie?
Okay, you guys, I see you're saying like some of you're going to be like in clinic just leaving. So I wouldn't expect anyone probably to get on at 12, maybe 12:15, 12:30, but I'll be there till 1. So just
because like I personally want to go, but I'm clinician in the morning, so I'm not sure what time I'll be done.
Yeah.
Hey Leslie, I have my ICP course tomorrow from 12:15 to 1:15. So would you mind recording it, because I can't attend, but I would like to.
Sure. Yeah, I can definitely record them. And if people show up and we have a good discussion, I'll post it. If nobody shows up, I won't post anything. So
Okay.
I have a couple of them. Yeah, I have a couple of them here, and I'll just send out the invite, like the day before. I have some Fridays, because my schedule is wonky because I have some things on Mondays and Wednesdays. And I realize you guys, I would do Tuesdays and Thursdays at lunch, but I know some of you travel. And then I thought Monica had some of those times for you guys for Q&A, and I didn't want to step on time that I was trying to find kind of a time that you might not have anything else, although I realize. And then Fridays, I'm in restorative all day Friday, but I do have like the lunch hour. So I put a few Friday lunch hours. So it's kind of like a mishmash, but I'll just send you guys out an invite with a Zoom link, and then just, come if you want. And I have lost everybody's faces. I don't know where did you all go? I guess you're up here. I do not know what's happening with my computer. It's like I have my share screen down here, and then everyone's face is way up there. Okay, so that is that. So the study guide is due tonight. So it's not due today at 1, it's due tonight at 9. And then I did adjust the submission place for the first assignment so that you can submit like up to 20 files. So that should be enough. If you happen to have to like submit like 20 pictures, if you can't get it in like one PDF document, then I opened it, the maximum was 20. So hopefully that should work for everybody. And okay, so that was all my announcements. So let's just, anybody have any? Let's go into the first PowerPoint then. I'm going to stop sharing and then pull up. So we're going to do the thyroid one first, which I think is a little backwards because I think your study notes, the diabetes comes first, but we're going to do the thyroid first because it's shorter. Okay. So thyroid disorder. So here are the objectives. So we want to explain the function of the thyroid and then the associated hormones that the thyroid secretes and produces. We want to recognize signs and symptoms of hypo and hyperthyroidism. And then we want to talk about the treatments for hypo and hyperthyroidism. So the endocrine system collectively is a whole system of glands that produce all sorts of different hormones, and they do all kinds of things in the body. So they basically send these hormones out to give direction for all kinds of different systems, and they make all sorts of things happen, regulate metabolism, growth, development, tissue function, sexual function, our sleep, our moods. I mean, it's just a lot of stuff. So they send these signals to the tissues and tell them what to do or what they're supposed to do. So if a gland isn't producing the right amount of hormone, or it's not doing what it's supposed to do, then we develop some kind of a disease, and it can affect so many aspects of our life. So the endocrine system is just super important system. And specifically, we're going to talk about the thyroid. So the thyroid gland is a really important gland in our system because it regulates what's called basal metabolic rate. And basal is like your baseline, so baseline speed of how a cell functions. So the thyroid gland is, you guys know this from your intraoral your extraoral exam. The thyroid gland is in the front of the throat, and it's kind of low, and it's right below your Adam's apple or your voice box. And you really can't feel the thyroid gland very well. So, you know, in doing your extraoral exam, you might be like, yeah, okay, there it is. But if it's a healthy thyroid gland, you probably won't feel very much. If it's swollen or inflamed or enlarged, you'll feel something. And it becomes more obvious. So the thyroid gland, this regulation of the metabolic rate, it's important for metabolism of carbohydrates, proteins, fats. It helps to maintain and regulate our blood pressure, which is super important. And then it regulates growth and development. So the thyroid gland produces and secretes a hormone called T4 or thyroxine. And this is then synthesized or turned into the active form of the thyroid hormone T3 or triiodothyronine. And this is the active form. So we have lots of T4, and then that is synthesized into T3. So T4 has very little effect on the metabolic rate. It's the T3 that really does everything. So T4, it's the major hormone that's secreted by the thyroid. It requires iodine for the synthesis. So we have to have iodine in our diet for the synthesis. And then T3, the triiodothyronine, at whatever target tissue, it's going to have its metabolic response. And in the liver, it's going to get converted to T3. The T4 is going to get converted to T3. So it enters the cells and it binds with those receptors. We're always talking about our hormones binding with a receptor and then causing the action, and then it becomes its active form.
Sorry, did you say that T4 goes into the liver and then is converted to T3?
It can be the liver or it can be other target tissues, but it happens a lot in the liver, but it can happen in other tissues as well.
Do you want us to know that specifically, Leslie? Like,
is that a question on the exam? Is that, oh man, I don't know if that question is specifically.
well, it's like, is that really important for us to like know? Like,
Yeah, I would say no. I would say if it doesn't say the liver on this slide, I'm going to say no. You can say it's just converted in the target tissues.
So it needs the
It's plate-
iodine to convert.
But it does need iodine, and you do need to know that it needs iodine. T4 needs, or the thyroid needs iodine to create these hormones. You do need to know that. So this is probably talking some more about what you just asked, Callie, but most of T3 comes from T4 synthesis, but a very small amount of T3 is produced by the thyroid gland itself, but most of it comes from the synthesis from T4. So iodine is required in order for this synthesis to take place from T4 to T3. And we mostly, in America, get our iodine from our iodized salt that's in our dietary, when you go to the grocery store and you buy salt and it's iodized. So that's where we get most of our iodine in our diet to help this synthesis process. So once the thyroid hormone makes it into the blood, it can either be, just like we were talking about other drugs, the thyroid hormone can either be free floating or it can be protein bound. But thyroid hormone specifically is incredibly highly protein bound. It loves protein. So you can see here on the slide, it says 99.9% of T4 gets bound up by protein and only 0.1% is free floating in the blood. And then 99.5% of the T3 that gets synthesized is going to be free floating. So obviously it's very potent and a little bit goes a very long way. We obviously don't need a ton of it to do its job because it's very highly. So most of the thyroid protein gets bound down. But what is bound down is active. It's the active form. The free floating is the active form. And it's enough to do what it needs to be done in the body. I did read, and I don't know that you need to know this specifically, but I did read that when your body uses the free floating, some of the bound hormone can become unbound and then can be ready to be used. So it's like, I guess it's not a permanent binding. It can disassociate from the protein, I guess. But most of it stays bound to the protein. So how does the body know how much thyroid hormone to produce, how much is needed? So the hypothalamus makes a hormone called the thyroid stimulating hormone that's made in the hypothalamus. And then it comes down to the pituitary gland and something else happens and then it makes its way to the thyroid. But TSH, or thyroid stimulating hormone, is made in the hypothalamus. And it is involved in what's called a negative feedback loop. And this negative feedback loop basically keeps the body in balance. So as TSH is released, it's released and then it stimulates T4 production. So as T4 production goes up, TSH starts to decline. It's telling the body, you don't need so much thyroid stimulating hormone right now because we got enough T4. But as T4 declines, then TSH starts to kick back up again. So it's this negative, they call it negative feedback loop. So it kind of is in a constant communication with regulating how much hormone to produce. So blood tests are the typical way in which thyroid disorders are diagnosed. So blood test, they measure the amount of unbound, so that free floating T4. And I've had my thyroid checked several times, and they always check T3 levels as well. This says, the book said T4 and TSH, but when I've had my thyroid checked, they've checked T3, T4, and TSH. So they do blood checks for all of them. But it's the unbound T4, TSH levels in the blood. And because of the negative feedback loop, if a patient has hyperthyroid, they would have increased levels of T4. If they're hyperthyroid, their levels of T4 would be up, and they'd have lower levels of TSH. And then of course, opposite if they're hypothyroid. So if they're hypothyroid, then they would have decreased levels of T4 and increased levels of TSH, just because of how that balances itself, what your body needs.
I have a question.
Yeah.
So if we have unbound T4, does that mean the body's not going to produce or synthesize T3?
Mm-hmm. Yes.
Mm-hmm.
If we have low levels.
We'll have hyperthyroidism because we have decreased T3.
Yes, yeah. So we don't have, so even if the body can't make enough of the T4 to synthesize it to T3, then we don't have that real active form that does what the body needs for that basal metabolic rate. So then the thyroid sometimes will get enlarged to try and work harder to make it happen, but it's still not happening. But that's hypothyroidism. Yeah.
Hey, Leslie.
Yeah.
I'm not sure if this is just what Yasmin asked, but the protein bound, if it's protein bound, it's like not getting used.
Mm-hmm. If it's bound to protein, it's kind of inactive. So the only thyroid hormone that gets synthesized and used has to be free floating thyroid hormone.
Like there's T4 that gets 99.9% is protein bound. So there's not a lot that's free floating. The T4 that's free floating gets synthesized to T3, and 99.5% of that is protein bound. Okay, so
So it's just a tiny bit that's like doing its job. We don't need very much of it to do its job. Okay. So here's a picture of a goiter. So this can be caused from a couple different things. So it can be that your thyroid gland is like working really hard to do something and it's not working. And so it gets enlarged and inflamed. It can also be from, it could be cancerous, and it could also be from Hashimoto's disease, which is a hypothyroid autoimmune condition. This can also be from not enough dietary iodine. We don't really see this. This is more common seen in other countries that don't kind of supplement their iodine through salt. But that is another possible cause of a goiter is lack of iodine in the diet. But let's see, the Hashimoto, so in Hashimoto's, it's an underactive thyroid, so it's hypothyroid. And the enlarged thyroid can also be cancerous. So I think I said that as well. So it could be a cancerous tumor. So those are different reasons why you might get nodules or goiter.
Hey, Leslie. It's just a side thing because I have Hashimoto's, and I have too much iodine, which is very common with people who have Hashimoto's in the US. And so they told me to always get salt that does not have iodine in it.
Wow.
Just a little kind of cool thing. That's
yeah.
Is that sea salt?
Yeah.
You get the real salt?
Just salt that does not have iodine in it.
I use non-iodized salt. I use something called real salt, and it has these little minerals in it. It's like the salt is almost colored. So it's like, you know how there's like Himalayan salt, but it's kind of like that, but it comes from Utah or something. I don't even know if it's iodized. It's just called real salt, and that's what I use. But now I'm gonna have to go home and look. That's interesting, Charity. Okay, so the etiology of hyperthyroidism. So the most common type of hyperthyroidism, or an overactive thyroid, is it's also autoimmune condition, and it's called Graves' disease. And with Graves' disease, the body has produced antibodies, like with a lot of autoimmune diseases, the body produces antibodies against its own organ, and it begins to destroy it. So when a person is experiencing hyperthyroidism, symptoms that they'll feel like, I always think of it as like hot and fast things, like they'll be sweaty and nervous and sensitive to heat, and their heart rate might be fast, and then they could lose everything's kind of running hot and high, so they might lose weight easily with Graves' disease. And then another thing that you may see is the bulging eyes, which I have an image of that here in just a second. And that is not always seen, but it can be from inflammation and a buildup of tissue behind the eyes, and it makes the eyes protrude, so kind of bulge out. There's the next slide is images of that. So that's from that kind of a fatty buildup behind the eyes, pushing them out from the inflammation. Okay, so treatment for hyperthyroidism, they'll use not so much anymore, I don't think, or is this, oh no, this isn't the one I was thinking of. So thiamide drugs, they inhibit the production of the thyroid hormone. So they try and kind of tamp down the thyroid. So that's one mechanism of treatment. Another common one is radioactive iodine, which essentially usually ends up destroying the thyroid gland, and then you become hypothyroid. So then you kind of take away one problem and cause another, but a hypothyroid seems to be easier to maintain or manage. So radioactive iodine is given to the patient. And then there are surgeries. When in my reading, it does seem that surgery is not always kind of the first line of treatment because there's complications with that. So it seems that there's other routes that are more common.
Leslie, are you wanting us to memorize all of the medications associated like that we read in the book?
I think the ones that are on the slides are the ones that are going to be more important for like the thiamide drugs here, like recognizing this methimazole and the generic what's that, Tapazole. So I think if you recognize some of them, especially if it's on a slide, so recognizing a hyperthyroid drug treatment, or the most common hypothyroid drug treatment, for example, like Synthroid or something like that. So I think recognizing if it's on the slide, I'm going to say is probably the most important drugs to remember.
You said Synthroid is hypo, correct?
And yeah, and we'll come to that slide in a couple seconds. But yeah, Synthroid or levothyroxine, that is one you guys will, in your careers, you'll see a lot of that. That's a really pretty common drug. Okay, so, and then another possible treatment is a solution called Lugol's solution. And this is a mixture of 5% iodine and 10% potassium iodide. It's iodide, not iodine. I think this is a typo that I didn't see earlier. But it's 10% potassium iodide and 5% iodine. And this is actually given to people when they're experiencing something called a thyroid storm or thyroid toxicity. Right now, I can't remember what it was. It's like thyrotoxic or something, but thyroid storm is a common word. And that's when they're like in hyperthyroid crisis. It's very dangerous and it's life-threatening. And you will likely not see somebody when they're in a thyroid storm. They're probably in the hospital, but it is absolutely contraindicated to have any kind of a catecholamine, which is like your epinephrine, norepinephrine. So no local anesthetic for somebody who's in a thyroid storm. But again, it would be incredibly unlikely that you'd have someone in your dental chair wanting a prophy during this state. So it's more typical that you have to be a little bit cautious of somebody who is hyperthyroid. You want to make sure they're stable and their medications are dialed in correctly, and you can always check with a doctor before you give epinephrine. Typically, it's fine. Typically, we can give local anesthetic to thyroid disorder patients who have thyroid disorders, no problem. But you know, there are obviously some caution things here and there, but that's an absolute no. But you just probably won't ever actually see it because they're very sick. They're not going to want to be at the dentist. So etiology of hypothyroidism. So another thing you might see in the readings is myxedema, and that just basically means severe advanced hypothyroidism, and that is myxedema, myxedema. But hypothyroidism is a deficiency in the secretion of T4, T3 from the thyroid gland, elevated levels of TSH because the body's trying to make the T4, but it's not working. It's more common in women. And then you see these signs, so kind of like it's like hot and fast when it's hyper. It's like cold and sluggish when you're hypo. You're cold intolerance, you feel weak, you feel tired, fatigued. People might have a hoarseness to their voice. Constipation and aches and pains. So when they're in if they're experience hypothyroidism, if they haven't started treatment and had the supplements yet. So those are signs and symptoms of undiagnosed. So treatment for hypothyroidism, this is the one I was thinking of. I got this one confused with the other one. So the thyroid USP or Armour, this one isn't really used so much anymore. They just use a synthetic thyroid hormone. But sorry, I'm up here at this one where you guys, all your faces are, but this is where my mouse is. So this one down here, this thyroid USP, this is, it's like, I think it's pig and like bovine. And I don't know if pig is the right word. Maybe you're supposed to say swine. I don't know, but bovine and swine thyroid hormone, but we just don't work very well with it. It causes a lot of allergic reactions. So really they mostly use this synthetic T4, which is levothyroxine, Synthroid. You'll see that a lot. I've seen Levoxil, and then there's other generics, but in my practice, in clinical practice, I've seen thyroxine, levothyroxine, and Synthroid. Okay, so hypothyroidism, congestive heart failure is like a possible complication for poorly controlled or excessive doses of thyroid drugs can lead to this heart failure, myocardial infarction or heart attack. So that's a risk. And then hypothyroidism, this adorable little girl, you can see that this image here, let me get my mouse in the right place. This image here on my left is before she started treatment. So kind of have a bit of like a swelling in the face. And there's some other distinctions that you can see in young people before they've gotten the thyroid balance of the hormone. And then here you can see how the swelling has kind of gone down in her face after she's probably started treatment of whatever that was. And then, so the good news is that if you have a patient who's has a thyroid disorder and they are well controlled, there's really not a lot that you have to think about as a clinician. You note their medication, ask if there's any changes, have they increased their thyroid or decreased? Have they had to dial it in or kind of do something with the dosage? Have they been stable? You want to ask them that. And if they're like, oh yeah, I've been taking the same dose for years and everything's fine. Then usually there's really not much that you have to think about. And then, but if the patient has been having issues and tells you that, then you may want a medical consult, say, especially if you're going to do scaling and root planing and you know you're going to have to use some local anesthetic. You might want to just do a quick medical consult, say, I'm going to use local anesthetic with my patient. Is there anything that I should be aware of? And, you know, just have that medical consult with their physician. And then, like I said before, the epinephrine's contraindicated with thyroid storm, but that's highly unlikely. You guys will see that. So any questions at all with thyroid?
Leslie, I have a quick question. So with someone who has hyperthyroidism, if they're in our chair, we should probably always get them a referral if we're going to do local anesthetic or something like that.
You can use safely if they have a relatively well controlled, they're hyper, but they've been under their physician's like watch and things are kind of maintained. You can use safely a small amount, maybe 1 or 2 cartridges. We don't tend to use nearly as much local anesthetic as dentists do. I mean, they can use like 8, 10 cartridges, you know, especially if you're an assistant, you've seen probably a lot. That's probably a little bit different. If most people you see will be hypothyroid and be taking a synthetic hormone, so that's the most common. So if you just don't see it very often and you feel unsure, you certainly can always do a medical consult. That's never a wrong thing to do ever. But you can usually safely give maybe a couple cartridges, 1 or 2 cartridges, even to someone who's hyperthyroid. As long as they have been, you know, well maintained. So you want to have that conversation and kind of find out where they're at. So there was one thing that I read that said, if somebody is hyperthyroid and they aren't well maintained and they've been struggling with, you know, the effects of that, and then they are in a stressed situation, they're about to have some big dental procedure, and then you give them a whole bunch of epinephrine, you can theoretically throw somebody into thyroid storm. So that's the big caution, but that would be somebody that's already not stable. So that's why those conversations are really important. So if they do mark hyperthyroid, then maybe just dig a little bit, see where they're at. Does that make sense?
Yeah, it does. Thank you.
Yeah.
I have a question very quick.
Mm-hmm.
I'm not sure when do we actually ask for a medical consult. Is it before like the patient comes to the clinic?
Yeah, so for you guys, if you're at all able to see their medical history, you can sometimes see the things that you might have a medical consult for. But you can also, do you mean like when you do it in clinic here at school?
Yes, like for example, like if I see the patient and then they have like a little bit inflamed thyroid, or if I see the medical history, they have hypo or hyper thyroidism, do I just like do I just like request a medical consult and then I delay the treatment, or what do I do? Like, I'm not sure.
Yeah, you might have to delay the treatment. Their high blood pressure or if they're diabetic and their blood glucose is too high, then you may have to delay the treatment until you've talked with their doctor and they're on a plan to come back with whatever it was lowered, like toggle their medication to lower their blood pressure, lower their blood glucose, or maybe they just came in and they didn't take their medication, or they didn't eat the right foods or something, and they can come back and it'll be okay. Or maybe they're uncontrolled. And so, but it's nice if you can get that stuff figured out beforehand, but sometimes they come in and you figure that stuff when they're in your chair, and then you have to deal with it. And so you just have to reschedule them because you can't treat them if they have their blood pressure is too high or their blood glucose is too high.
Okay. All right. Thank you.
Mm-hmm. Okay, so let's take a little break. What time are we at? 1:47. So let's take like a 5-minute break, and then we'll come back and start diabetes. So come back at like 1:53. I don't know, something like that.
Leslie, can I ask you a question while we're on?
Yeah.
So I don't know about anybody else, but I'm personally kind of struggling a lot with this like alpha beta thing.
Okay.
But I think I kind of just figured it out. So when you're talking about like agonists and antagonists,
Mhm.
so like if you're saying so like A1, they're located on smooth muscle and they produce smooth muscle contraction. So if
Yeah.
you take an A1 antagonist, you're stopping the contraction of the
Yeah.
so it's just like literal. I don't know why I just struggled so much with the concept.
It's not an easy concept.
Like I really was having a hard time. So basically whatever that um like receptor does or whatever, it's like an agonist, it's saying, okay, we're gonna produce production of smooth muscle.
Yeah. Let's do this. Let's stimulate it. Let's get it going, maybe even more than normal. Mhm.
Okay. But it only affects that like it wouldn't affect like an A1 wouldn't affect a beta.
Yeah, it wouldn't affect a beta, but if the drug does have, because they're not always selective, that's where that selective and non-selective comes in. It's not always as selective as we want it to. So there are drugs that will do what we want it to do on an alpha 1 receptor, but then it may actually end up doing something to like the alpha 2 receptor or whatever else is around there. It might have an affinity for that for some reason. And so they try to make the drugs selective and really specific, but it just doesn't always happen. So that's why you'll see some drugs used more for one particular reason, because they're really good at just doing that one thing that we want them to do. So that's where that selective and non-selective comes in.
I don't know if I see, I mean, you didn't really highlight that in the PowerPoint.
Yeah, I don't know that there's much in the
It's
text.
not, I didn't see anything about selective and non-selective in the PowerPoint. So, I mean, it was in the book.
Mm-hmm.
But it's taken me honestly like a whole week to understand this concept, I swear. So yeah.
I know it is. Oh, and that reminds me, I don't know if anybody saw this. When everyone comes back, I made some flashcards for the beta 1. Did you see that? Did it work? I didn't even know if it was going to work. I just was playing around. I was like, ooh, that might be kind of fun. And so I made it. I couldn't tell if it really worked.
Yeah, well, I went into it, but I was still trying to grasp like the understanding. So I didn't even like attempt it because I was like, I don't even know what I'm looking at yet.
Mm-hmm.
But I can go on it right now. I think that it did work though.
Okay, good.
Yeah. But I saw what you were talking. Oh, it's literally like cards.
It is. I think it's like, I don't even really get
that works.
Flashcard.
Yeah, you just click on it and then it asks you the question and then it
flips it over or something.
Yeah. I think I was getting confused with like the adrenergic and the
yeah.
Like because they're all adrenergic. The alpha and beta, right?
Yes. Yeah, because they're all the sympathetic nervous system.
Yeah, so I was just it's like I knew what each word meant, but when you were putting it all together, I was like my brain was having a seizure.
There's too many A words.
Yeah.
And they're all big A words. And they're hard to say. Yeah. They're all adrenergic because they're all sympathetic. It's a tongue twister. Okay, let's see. I'm going to find the next PowerPoint.
And Leslie, we don't have a study guide due next week because we have an exam, correct?
Right. Yes. Let me go back to the. Yep. So next week, there's no quiz, obviously, because there's an exam, and there's no study guide. It's just the exam. So we'll log in. I think Monica's going to help me proctor. And so we'll log in and then take the exam. We'll have an hour and 20 minutes to take the exam. And then if there's any time left afterwards, anybody who is in, I think what we'll do is if there's time left over, I'm going to log in to the regular Moodle link that we use every week. And if anyone wants to come in there for the rest of the class time to ask questions or something about what the quiz, then you can do that. So everyone can leave their exam Zoom link and go into the other one. You don't have to, you can be done if you want. You can just, I'm not gonna lecture or anything, but I'll just be in there until the regular class time ends if we don't take up that whole time for the exam. So if anyone has any questions or anything.
How many questions is it?
It's 50, it's 50 questions.
And we start at what time again?
We'll start at 1 and then we'll probably take 15 minutes to log in because I don't know if I'm going to do all of you guys or if I'm going to share it with Monica. I don't know. She offered, she's so sweet. She said, it'll just take me a little bit longer to get you guys all checked in, but then I have you all in one room. So I'm kind of like trying to debate. But I'll send out the message so you guys know, of course, in advance. But anyway, so 15-ish minutes to log in, especially if I'm sharing the proctoring, and then an hour and 20 minutes for the exam. And then that leaves like maybe another 15 or so minutes at the end, possibly. So if everyone is in one room, then I'll just stay in there. But if I've shared the proctoring, then I'll go to our regular Zoom link for class, and I'll be there if anyone wants to come in and ask a question if they had a problem or were frustrated about something with the exam or had a question about the exam. I did want to show you guys. What was I going to show you? Oh, real quick, just this. I put this in here, this adrenergic agonist and antagonist flashcards. So it just says what the beta 1 agonist does, the beta 1 antagonist, the beta 2 agonist, the beta 2 antagonist. It just says what they do, basically. So it's like flashcards to help you memorize those functions. And I think it talks about what maybe it doesn't do the medication. It just says like the body system, and then if it like how it responds to that body system or to that tissue, target tissue. So that's in week 2. And then down here in week 3, there's this little video on how to take patients' blood glucose. I did that video kind of rushed at the beginning of the semester. It's not great. You guys will Monica will probably go over it with you guys again. Typically in this class, we do it in a classroom and we sit there and kind of play with them. So it's kind of hands-on, but we don't have that opportunity in this class. So I figured, well, a video at least gets you going, and then I'm not sure if she's going to show you guys but if anyone ever wants to come into my office and kind of ask me how it goes in person, we can talk about it too. Or I can demonstrate it again on Wednesday if you guys want to. But okay, so let me go to the next PowerPoint, the diabetes. What is going on? Okay. Okay, so the objectives for this one is to identify the anatomy and function of the endocrine system relating to diabetes. That's kind of a very mild objective. We don't spend a lot of time on the anatomy portion. Explain the prevalence, the etiology, pathophysiology, complications, clinical signs, risk factors of type 1 and type 2 diabetes. We want to recognize selected common medications. So try and focus on what medications we might see most often used in the treatment and prevention for both type 1 and type 2. And then discuss adverse effects of the selected diabetes medication, so some side effects, and then describe therapeutic effects of the selected diabetes medication. And okay. Okay, so this, I updated this. So diabetes is like definitely an epidemic in our country. And I don't know, the PDF that you guys have uploaded in Moodle, I don't think that slide is more than a year or two old. I don't think it's very old, but I updated mine because I went to the CDC just to see what new like infographics and stuff they had, if I liked anything better. And this was their updated slide, which is pretty much the same thing that's in the PDF that you guys have, but you can see it's like practically 5 million people more. So it's already increased. The prevalence of diabetes has already increased since, you know, that other slide was put in there. So so the number, about 35, just under 35 million people have diabetes in the United States. That's 1 in every 10 people, and 1 in every 5 people don't even know they have it. So type 2, this is of course this is encompassing all diabetes, type 1 and type 2, but the people who don't know they have it are almost certainly type 2 diabetes. You wouldn't not know you had type 1 because that just doesn't really happen. I mean, maybe for a very short period of time, but then you'd know for sure. Where you can live with type 2 diabetes and not really know it, maybe have some feelings that you're not well, but you can still live, you know, for a while before things get really bad. So this next one is just some more, this is from the CDC. Some more facts of demographics. So 34 million people have diabetes. Diagnosed about 26.9 million. This is that 1 in 5 people who are undiagnosed, about 7 million. And then there's a huge population of people who are pre-diabetic, and we'll talk a little bit more about that in a later slide, but 88 million people are considered pre-diabetic, age 18 and older. So that's 34% of the US population. That's just huge. And then 65 years or older, about 24 million people are pre-diabetic. They used to talk about it being, you know, like an adult onset or something that you get as you get older, but now we're seeing more and more often young people starting to develop type 2 diabetes. So the cost of diabetes is huge. Medical cost that includes lost work and wages, and then the medical costs and all the comorbidities that go along with it, $327 billion yearly. And then medical costs for people with diabetes are twice as high than for people who don't have diabetes. So it's a huge medical cost burden to everybody, really. So let's kind of talk about why it happens in the whole system. So what happens when we eat? Well, we eat to fuel our bodies. So the food we eat gets broken down into glucose. This is going to be like very basic 101. This is not like in depth, but it gets broken down into glucose, and it's in our bloodstream. And we need to get it to our cells for it to be to actually work as energy for us. So our food breaks down into glucose, and it hangs out in our bloodstream. But then what? It's got to do something else. So then we're going to use a hormone that's produced in the pancreas. More specifically, it's produced in the beta cells of the islets of Langerhans. I think I'm pronouncing it right. So the beta cells of the islets of Langerhans produce this hormone, insulin, and insulin basically acts as a key to open up a cell to allow that glucose that's in the bloodstream to come into the cell. So if we don't have insulin, then the glucose is going to stay in our bloodstream. And we know that as hyperglycemia, high blood sugar. The glucose, the blood sugar is high. So we need that insulin or that key to open up the cell and then let the glucose in. So I think if I toggle, this does like a little animation. Oh, I missed it. I did it too fast. So there's the key. The cell has opened and the glucose can come in. Okay. All right. So in a healthy person, somebody that is not struggling with diabetes, your body regulates this on normally. Like it's kind of like the thyroid gland, right? Like if you eat food and you get a blood sugar spike, your body goes, oh, we need insulin. And so then your pancreas produces and secretes insulin. And then the insulin opens up the cells and the glucose in the bloodstream come into the cell. So this just happens automatically and it just is self-regulating. But you can see here in these little pictures, if we have low blood sugar, we're hypoglycemic. Normal is like just the right amount. You've got some insulin in there, we got some glucose, or we got our glucose in there. We have the white and the red blood cells. And then hyperglycemia is there's just too much blood. There's too much glucose in the bloodstream. Okay. So then what is diabetes? So it can happen, it can be classified in sort of three major things can be happening. So an individual with diabetes can either have no insulin, their body is not producing insulin, or it's producing it in such a little amount that it's just not making a difference. So it's either no or too little insulin. Or the second way, the liver can just be producing like way too much glucose and the body just can't keep up with it. It's just like glucose, and the body just can't keep up. Or the last one is there's enough insulin, but there's something going on with the cells and the receptor, and they're just not utilizing the insulin in a way that is actually getting the job done. So you have those kind of three things. Those are the three possible reasons where you'd end up with diabetes. And so this is just sort of demonstrating the same thing. We have too little insulin is made, can't use the insulin well enough, or the liver is just making way too much glucose. So this is kind of a crazy looking slide, but this is just to kind of gives you an idea of the levels. So we have that, green is good, green is go. Yellow is caution, yellow is pre-diabetes, red is stop, or red is not good, and that's diabetic level. So we have these different tests and the levels of the blood glucose here, and then we have an A1C test, and we'll talk a little bit more about those. But those are just showing you some numbers, some healthy numbers that you'd see in like normal after a fasting blood sugar test. You'd see someone right around the 99 mark would be a normal, healthy range. Or if they took something called a glucose tolerance test, it might be a little higher. It might be in the 140 range, but that's still your body processing everything in a normal way. And then if you take a 3-month snapshot of somebody's blood glucose over a 3-month period of time, then they should be somewhere in the 5.7% range. That's like a snapshot over time of what their blood glucose has been. But a serious but treatable condition is prediabetes. And so just to kind of talk about the pre-diabetic state just a little bit here, it's obviously, it's too much blood sugar. So you're over the normal range, but you're not high enough to be considered diabetic. So you're in this kind of in-between phase. And studies are showing that people can either prevent that transition into type 2 diabetes. So just because you're pre-diabetic doesn't mean you're going to go and into full diabetes, especially if you make some lifestyle changes. So they're showing increased activity, moderate weight loss, probably obviously something in the diet changes too, that usually takes up, is a part of it. And then some doctors might prescribe an anti-diabetic medication like metformin, even in the pre-diabetic phase. If they have a very strong family history of diabetes, they may prescribe an anti-diabetic drug, but usually the route is lifestyle changes is usually. But it's really important to try and catch somebody early, educate them, and get them to, seriously to think about this, because there are so many comorbidities and health problems that come with full-blown diabetes. And if you can prevent that and reverse it, I mean, it saves your health and money, obviously. So most people with pre-diabetes develop type 2 diabetes within about 10 years. So it is, usually a progression. And these blood tests that are used, like up here or here, where you guys can see my mouse, here you can see these different blood tests are determined to find out if someone's pre-diabetic or diabetic. And that is the fasting plasma glucose test, or FPGT, and then the oral glucose tolerance test, or OGTT. And then, okay, let's see. Next slide here. Okay, so let's talk more about the two main types of diabetes. So we have type 1, that is an autoimmune condition. This typically comes on early in life. Usually they used to call it juvenile diabetes because it came on earlier in life. But now it's type 1, but it's defined as either a great reduction of insulin or no insulin at all. And these patients are going to be insulin dependent their whole life. They're going to have to, that's the medication that they're going to need, and they're going to need it for their whole life. Then there's type 2 diabetes, and this is generally there's enough insulin is being made, but the cells just aren't utilizing it well. They're just desensitized to it, and there's just something with the receptors there that's not working right. And with this type, the pancreas may even stop making insulin over time. So if this just keeps going on, the pancreas might just kind of give up and be like, you don't need me. And then they may end up needing to take insulin. And type 2 usually comes on later in life, but more and more we're seeing type 2 diabetes in kids, but it also is seen with a strong family history of type 2 diabetes. So here for type 1 diabetes, it's usually about 10% of the population of people who have diabetes, they have type 1. So they say 1 in 10, it's type 1. Most often it's, you'll see it diagnosed in somebody 20 and younger. So it's usually, when I worked with a lady who, she had a young son who was diagnosed type 1 diabetes when he was like 10-ish, somewhere around then. And then a few years later, her 16-year-old daughter got type 1 diabetes. So she had both her kids got type 1 diabetes in a matter of a couple of years. But so the body can no longer make insulin, or there might be like a tiny little bit of the beta cells in the pancreas that are still making insulin, but it's not enough, and they may end up being all destroyed by the antibodies eventually. So they're always insulin dependent for the rest of their lives. So type 1 diabetes, the main deficiency is that they're not making insulin. But what you see in the body is hyperglycemia. That's what you see. And so it's like, that's like kind of what you think of as like the disease, what's happening, but that's secondary to the fact that they just don't have insulin. They're not making insulin. So insulin's not being produced. And of course it's needed to help get the glucose into the cell. But the beta cells have all been destroyed, and they're in the pancreas as a reminder, and they've all been destroyed. So usually by the time somebody gets to the diagnosis part where they're sick enough and they go to their doctor, something's not right, like 80 to 90% of their cells, their beta cells have already been destroyed. So there's almost always it goes to insulin dependency. Okay, so some symptoms that would come on fast would be weight loss, loss of energy, Increased thirst is polydipsia. Sometimes you'll see these words, just even on the boards, they'll use some of these words so it's always good to kind of write, like increased thirst, polydipsia, frequent urination, polyuria, hunger or increased hunger, polyphagia, and just kind of have those terms in your brain, or sialuria is like drooling. So there's all these, and you'll get those in different classes, but just always keep those running terms in your head, because those are like, people love those on board questions, on the national boards and stuff. They always use these weird phrases and you're like, what does that mean? I remember what it means, but it's like that medical terminology. So type 2 diabetes, so the majority of people with diabetes have type 2 diabetes. So 9 out of 10 people have type 2, usually diagnosed over the age of 40. So typically it's something that comes on later in life, but like I said, more and more young people are being diagnosed. And then type 2 is more likely affects anybody who is overweight or belongs to some specific ethnic groups, which was shown in another slide, or if they have a family history of type 2 diabetes. So if, aunts and uncles and mom or something has type 2, then you're probably, at much higher risk of getting type 2 diabetes. So this just shows how, like in the 1940s and 50s, the prevalency of type 2 was relatively low, and it's just kind of steadily increased. But we didn't ever really see kids with type 2 diabetes until about the early 90s, maybe late 80s, and then maybe a little bit here and there. But now it's like we're just there's like an explosion of seeing more kids developing type 2 diabetes, which is really scary because so much can happen in somebody's older years if they've had type 2 diabetes from, say, 60 to 80. But if you take like a 15-year-old or a 12-year-old and they have to live with managing their blood glucose levels and fighting hyperglycemia for their whole life, there's just a lot of damage that can be done and a lot of other comorbidities that can go along with it. So it's really sad. And so we have to find a way to fix this and reverse this. So type 2 diabetes, so it's 2 to 4 times higher in minority populations. And so American Indians, Alaskan Natives, African Americans, Hispanics, and Asian Pacific Islander population. And what they have found in studies is that generally as the education level of somebody, as their health literacy improves, their rate of lots of diseases decrease. So they'll have less, but I was really thinking about it, and just on my own personal thought rant, I think about, for an example, a population like the Native American population and those that are living on reservations. And what do you guys think could possibly affect, all the education in the world can only do so much if your resources are like completely limited, right? So what do you guys think about that? Somebody that comes in and says, oh, you shouldn't be drinking all this soda, and you should be eating more fruits and vegetables and not so much this processed food. But if you go to the little market and all you have there are highly processed foods and Coca-Cola beverages and things like that, and you're on kind of an isolated rural area, then what do you do from that point? So it is education, but I feel like it's access to resources. Does anyone have anything they want to add to that?
Stuff like that is also more expensive, in my opinion. So it's funny because, like, I'm not afraid to admit it. So like my son has been on WIC for, you only get it till they're 5. But like if you look at the things that you get on WIC, you get healthy things, but like he gets 2 things of juice.
Yeah.
So like stuff like that. And like I mean that's probably like the only thing I could really point out, but like yeah, you get like 2 big cartons of juice.
I completely I completely know what you're saying, Megan, because it's like it's more expensive oftentimes. I mean, there are really creative ways to buy super healthy food, but if it's like a massive learning curve, it takes more time, more work. It's low on priorities if you're struggling for other resources or doing other things. I mean, it's such a layered issue. This is probably for another class and not for oral pharmacology. But it just got me thinking, like, the slide just said how education level is so important, and it's true, but there's so many things on top of that. Access to what you're given, like what kind of foods, if the government is, offering resources, what are they offering? Are they offering stuff that's actually really super healthy, or are they offering stuff that can increase your risk of diabetes? So it's, I think you guys haven't started public health yet, have you? I think that's where you'll get into these conversations, which are always good conversations. I always want to be a fly on the wall. Okay, so what is type 2 diabetes? So type 2 diabetes, again, just like type 1 diabetes, hyperglycemia is secondary to the main problem, which is the insulin, resistance. So your cells just it's just not dealing with the insulin correctly or efficiently. But what your body is gonna, start showing you, or what's actually going to make you sick, is the hyperglycemia. So insulin production is sufficient but not used well, and then insulin resistance occurs when your cells have a decreased sensitivity to it. We already kind of talked about that. So symptoms for type 2 diabetes, again, are that increased thirst, increased urination, feeling tired, blurred vision. And sometimes this stuff can be mistaken for other things, especially if someone isn't particularly overweight and doesn't have something that might trigger someone to say, well, let's check diabetes. And you might, I'm tired and my eyes are blurry. That wouldn't necessarily send someone right to diabetes, right? So sometimes this stuff gets missed. So over time, though, high blood sugar from diabetes can damage blood vessels as well as the nerves that control heart and the blood vessels around the heart. So diabetics are far more likely to have other conditions that raise their risk for high blood pressure. So a lot of times when we have our diabetic patients come in and their blood pressure is also high, that's not surprising. Also, they're at risk for too much LDL, which is the bad cholesterol, and that can build up in our arteries. We have that atherosclerosis, the hardening of the arteries because of the plaque buildup. So that, of course, leads them to, an increased risk of heart attack or stroke, high triglycerides. So the too much bad, too little good cholesterol. And so they're just at, higher risk for these other complications. So here we talk about the macrovascular complications from diabetics, and that leads to the things like stroke, heart attack, poor circulation they poor wound healing. And then they have increased risk for congestive heart disease, peripheral vascular disease, stroke. But coronary artery disease is a major cause of death for both type 1 and type 2. Because remember, they're both kind of dealing with hyperglycemia, and it's this over time, this constant hyperglycemia is what causes a lot of these other health problems. So the high blood sugar damages nerves, so they can have neuropathy. It also weakens the walls of the very small blood vessels, the capillaries. And so this can lead to problems, kidney disease, blindness, numbness in their hands and feet, all kinds of other peripheral nerve issues as well. So this is going to be drilled into your heads over, and you're going to go to CE courses about this. This will never stop being a major topic for you as a dental hygienist. But essentially, diabetes and periodontal disease are kind of in what's considered like a bi-directional relationship. One sort of affects the other. So our patients who are uncontrolled diabetics have a very strong tendency to have periodontal disease and for it to be not stable periodontal disease, like active periodontal disease. And then patients who have active periodontal disease are at greater risk of having harder to control diabetes. Their blood sugar is harder to control. So it's this kind of vicious cycle. So you can see here on the slide, it says people with diabetes are twice at the risk of having periodontal disease. They're at risk for increased dry mouth and fungal infections, Candida albicans. If they're poorly controlled, it's obviously way worse. And they're far more likely to have severe periodontal disease. So if their A1C is really, if their A1C is, you know, definitely above a 7, but if they're into the 8 and 9, that is poorly controlled diabetes. 1/3 of people with diabetes have severe periodontal disease with loss of attachment of the gums to teeth measuring on average 5 millimeters or more. So they're usually into that moderate to severe periodontal disease, not the mild. And then the role of periodontal inflammation is a major component in the pathogenesis of diabetes and its complications. It's more complicated than what we'll get into, and you'll talk about it in other courses, but essentially that inflammatory response is getting in the blood system is part of what makes it harder to control the blood glucose. So it's this bi-directional relationship, one affects the other. So what can we do as clinicians? Good oral hygiene, you know, talking to anybody who we see who's our periodontal or our diabetic patients, but for sure our diabetic patients, talk to them about if they're relatively healthy and stable, you know, keeping on these good regimens, seeing them twice a year at least, if not more, if not every 3 months, keeping their oral hygiene pristine, working on that, controlling that biofilm, and then of course maintaining their glucose, so staying at a healthy blood glucose level. Let's do another break. Let's do another like 5. Let's come back at 2:30. Let's do another little break.
Leslie, I didn't realize you were going to be in our class yesterday.
Oh yeah, I didn't do very much, but that's why I like that class because I loved like hearing what the other professions and you guys talk about. Like I'm more just kind of like like I just sit there listening, but
Because Callie and I are taking it too.
yeah.
And we're like, oh my gosh, they're just like a bunch of doctors in here. We sound like idiots.
No, you didn't. You guys, I was so happy that you guys spoke up because honestly, some of them might be third year, they might be more whatever, they've been around long enough to sound refined and doctory.
Yeah.
They're still students, but this is my third year in there, and I don't think any dental hygiene have ever been in there yet. And so I love that you guys were speaking up and part of it, because there's a lot of freshmen, like OT freshmen or physical therapy freshmen. Through the years, I've seen, well, you're not freshmen, but you know what I mean, first year. And so no, I thought it was great that you guys joined right in, and it makes half the time some groups just sit there and are just like, so it's
Yeah.
anything that you say to contribute to the breakout room, somebody else will vibe off of, and it's great. Yeah.
We immediately started talking about dental, like immediately. And I was just like, okay, I'll say my piece and then I don't have to say anything else.
I'll have said my 2 cents. I know that's I talked, I did my thing. I don't have to talk anymore.
Yeah, pretty much.
Is it still snowing? Are you guys still? What is it doing in Scappoose right now, I wonder? Oh, it's 2:30. Oh, we better get back. Okay.
Well, it's not
My
snowing.
family is outside having a snowball fight.
Dang it. It's not snowing in Scappoose, it doesn't look like, but I'll probably be
it's not snowing. I'm in St. Helens. It's not snowing.
Oh, you are in St. Helens. Okay. Yeah, I bet it'll be snowing over the pass.
Yeah.
Okay.
We live up in the country and it's snowing down really hard. It's sticking. And I wish I could show you guys pictures in the chat, but
it's so beautiful. I love the snow.
Maybe we'll get a snow day tomorrow. We don't have to do anything.
Oh, that would be nice. You guys are in clinic. Yeah. I keep looking at the senior schedule, but you're in clinic tomorrow. Yeah, maybe you'll get a snow day. Okay, so we have about 19 more slides. So hopefully we can get through these pretty quick. I think we will be able to. So the good news about diabetes is that people, type 2 diabetes, not type 1, but type 2 diabetes, type 1 diabetes, if they're able to maintain their blood glucose, and this is true for them too, keeping the blood glucose as near normal as possible, as often as possible, is the best way for them just to lead a normal, healthy life without a lot of these comorbidities and other problems. That includes learning self-care skills and being informed education on, diet, when to take their medication, when to eat what foods they can't have too much of, like all of these. And there are diabetic educators that's their whole job, is to just get people to understand what they need to do when to stay healthy. They need support from their family, because if their family doesn't support their dietary and exercise and all this kind of stuff, then that's difficult, and then of course taking their prescribed medications at the right times and getting access. Insulin's very expensive. And can you imagine not being able to afford your type 1 or your insulin dependent type 2 and you can't get insulin? There's that's oxygen. You need it. You can't not have it, so it's pretty scary. People with diabetes can lead totally normal, full productive lives, especially obviously if they're well maintained. So this next slide is just showing, if they keep on target, type 1 diabetes, if they keep on track with their blood glucose levels, they're going to decrease heart disease, kidney disease, nerve damage, eye disease. All of this stuff is dramatically reduced if they're able to stay in healthy ranges. And the same for type 2. Keeping an A1C in the target range reduces heart disease, eye damage, kidney disease. So we'll talk a little bit about the medications next. So the diabetes management plan. This is not in your PDF that I uploaded. I kind of went through and did a few very tiny little edits that I think won't matter for your exam at all. Some of them were just some demographic numbers, but like this, for instance, this whole thing is in your clinic manual. I just copied and pasted it. This is what you guys need to know for clinic. So if you have a patient who has a on record A1C of 7% or less, then you can blood glucose limit up to 250 if the patient has a current A1C. So if they're having a bad day, but they have an on record A1C of 7% from a recent test, then you can take their blood glucose and it can go up to 250 and it's okay. But for anybody else, really, and for elderly patients, it can be up to 7.5. But for anybody else, it has to be below 200. So if you take their blood glucose and it's 199, then you can see them. But if it's 200, then maybe they just ate and their insulin needs to kick in and get some of that glucose out of their blood. So it could be something like that. Maybe you walk them around the clinic, give them some water, and then take their blood glucose again. But this is straight out of your clinic manual. And then 300 milligrams per deciliter, if they're up to 300, then they need a referral to their doctor. And I think we have even talked about, maybe that's blood pressure. That might be blood pressure that I'm getting confused. Walking them down to Virginia Garcia, I think I'm thinking of something else. But they do need a referral to their physician because they need to know that's not good. That's not okay. But what is the A1C? So here you can see it's glycated hemoglobin levels. So the glucose binds to the hemoglobin for life. So that's why they can take a snapshot over a 3-month period and see how much hemoglobin and glucose have been bound together over that course of that 3-month period. And that's where they get the A1C percentage from. So it's a snapshot over time of their blood glucose levels. So this is just a conversion chart. Typically, if somebody's in the 7 range, which we consider like a well-controlled diabetic, 7 or below, typically their blood glucose is going to be decent, 150. It's a little high for the rest of the population, but for a diabetic, it's not bad. But it could certainly be less than that also. I mean, I've seen lots of people in our clinic who are diabetic who have a lower blood glucose, but that's just kind of an easy conversion chart. So another good news is that patients or people who have diabetes, if they increase their physical activity, losing, maybe a moderate amount of weight loss, all of these things can reduce, can improve their diabetic stance, whatever I'm trying to say. It can help keep them maintained and healthy. So it can reduce their need for medication. They can, of course, you're going to feel better. You're going to have increased energy. You're going to mentally feel better. Exercise makes us all feel better. And of course, overall improved health. So physical activity for patients with diabetes is really important. It's important for all of us. Heck, I need more. I've been doing 30 minutes on my bike every day on my little exercise bike, but I feel like I need even more than that. Okay, so medication. So it's pretty easy for type 1 diabetes. It's insulin. And then we'll talk a little bit about there's long acting, short acting, that sort of thing, but pretty much insulin for type 1 diabetes. Type 2 diabetes, they may take an oral medication. They may take an oral medication and insulin, or they may take insulin. So it just depends. So for the oral medications for somebody who's type 2 diabetes, there's a couple different categories. So the first one is the biguanides. This is your glucophage. Metformin is the generic. You will see this a lot. Metformin is very common. Glucophage, very common. You'll see that a lot. Its mechanism of action is it decreases glucose production from the liver. So it's working on the liver and how much glucose is produced there. You can see type 2 diabetic oral medications combined. So these are different. So this is like a biguanide mixed with a sulfonylurea, I think, or maybe this one, glipizide. But they're like a couple different medications in one pill. And you'll see that when we go to the next slides. But that's what these are down here. These are combinations of different categories of oral medicine for type 2 diabetes. So another one, so the side effects, major side effects for the biguanides is nausea, diarrhea, vomiting, possible weight loss. Usually people ramp up slowly and the side effects get better with time. So usually they'll start low and they'll maybe ramp up the dosage and the side effects will get better. So the next category of the oral medicine is the sulfonylurea. So that's your oh my gosh, I can say glipizide, but the other ones I struggle with. Glympuride, glyburide, chlorpropamide. So those are your generic names. And then the brand names are a little easier to say, the Amaryl and the Diabeta. But those can be combined with the biguanides. So they can combine those, and there's another class that we'll see in the next slide that can also be in a combination. So sometimes, but these act on the pancreas to produce more insulin. So this is stimulating the beta cells in the pancreas to produce more insulin. That's what the sulfonylureas do. Stimulate the pancreas. Okay. Side effects from too much of this medication would basically be hypoglycemia. So if a patient has taken this medication, increased the amount of insulin, and for some reason they haven't eaten enough or whatever, they probably they missed a meal or it's been too long, or they were more active and they burned through their food faster, but they still took their medication, then they're going to have hypoglycemia. They're going to feel confused, pale, sweaty, clammy. I get hypoglycemic sometimes. It's the worst feeling. I hate it. And just shaky, and just like an anxious feeling. It's just very yucky. So that's a side effect of a sulfonylurea. And then there's the insulin sensitizers. These drugs improve insulin sensitivity on the receptors of cells. And this is the Avandia and Actos, or rosiglitazone and pioglitazone. And some side effects for these insulin sensitizers would be fluid retention, weight gain, headaches, muscle pain. It can elevate liver enzymes. So sometimes they have to check the blood level of liver enzymes if they're going to take some other medication. They should not take it if they've had a history of heart failure. So there are more things to be concerned with these insulin sensitizers. And it can increase ovulation in menopausal women. So that would be shocking if you were, if it increased your ovulation and somebody thought they were entering menopause and they ended up being pregnant. And then it can decrease the effectiveness of birth control too. So those are important things for women in the birthing years to think about or to know about. So for insulin, these are all, just so you guys, because it didn't really say it very clearly, but just so you know, these are all generic names for these. So there are brand names that are different, but these are all generic. So I am assuming on an exam that it'll, if it's on an exam, it'll be in these form, this generic name. I do have found a chart though that I can post this. I have this PDF chart that I can post in Moodle that has these generic names and then their corresponding brand names. So I'll post that for you guys just for information, but I don't know that you'll need it. Maybe it was in the text and I just can't remember. But there's basically all of these insulin it's the onset of action. So there's rapid onset, and then there is short acting insulin, which is kind of the regular insulin. It just has a short acting life. Then there's intermediate acting, and then there's long acting. And people can take different ones in the same, they have all different ways of drawing the insulin up into the syringe so that they have like different acting that they can take at the same time, or their insulin pump will give them some of the short acting and then some long acting. So it tries to mimic the body's natural response to like eating food and then processing something that's in your bloodstream longer and that sort of a thing. Make sure I'm not running out of time. 6 minutes. Okay, so hypoglycemia is obviously someone who's taken their insulin again and not eaten or done more physical exercise or stressed out and they're just burning through their food. So hypoglycemia is a major side effect of somebody who is on a regular insulin or medication. So that's to, so we always have orange juice and crackers and stuff like that in the glucagon or the little glucose tablets and stuff like that in the clinic. So what affects blood glucose? So what increases blood glucose is physical stress or illness that can increase. So it's like periodontal disease is like an infection or an inflammation that can increase glucose. Emotional stress can increase blood glucose. And then carbohydrates, obviously what we eat, and then certain medications. What can decrease it is exercise, so burning through that fuel, and then certain medications can decrease it as well. So now I just want to quickly talk with you guys about the glucometer. I'm just going to check the last slides before I do. So what can you do if diabetes or uncontrolled is suspected? So in our clinic, we check patients who have a history of, if they mark family history and you've never seen them before, you'll take a blood glucose on them. If they mark pre-diabetes, you'll take a blood glucose reading. If they mark diabetes, you'll take a blood glucose, and you'll do it every single time they come into your chair and you're going to do some kind of invasive treatment. We refer patients to their physician if we get a high blood glucose and they didn't know, then we refer. So we're kind of like a nice screening. We screen them and give them some information maybe that they didn't know, and encourage patients to care for their diabetes. So we have a perfect segue into why they should maintain their diabetes and try and keep their blood glucose levels stable. And then we teach them about their risks of increased periodontal disease. So we have this like perfect window of opportunity to help their oral health and their overall health big time. So did anybody watch the video? These are just some resources. So I know we have 4 minutes. If you haven't watched the video that I posted, please do. I know it's not the best, but basically what you're going to do in clinic is when you have this guy here, you have this little guy, you're going to take this tab and you're going to slide it in, not all the way. So you don't want to put it in till it stops. You want to put it in like 90% of the way. And then you're going to poke your patient, use the little lancet, and you're going to poke your patient's finger. And here's a tip, poke it on the side or sort of not, just don't do the pad, because you have way more feelies, nerve endings in your pads of your fingers, and it's going to hurt more. So if you poke them sort of more on the side, you'll get more blood and it won't hurt them as much. So kind of do the side of their finger, and then you're gonna, I actually read you're not supposed to squeeze it a whole bunch, but I squeezed mine a whole bunch and I got lots of blood. So you kind of squeeze it a little bit, make sure the blood comes out, get the blood onto your little tab, and then push it in. If you get it pushed in, there's a timing, there's a rhythm, and you all will probably get an error. I've gotten an error before. It's a timing thing. You'll get better at it as you take the blood glucose in clinic, and you'll take a lot of them. So you'll have plenty of practice. But if it gets an error, you simply maybe put the little stick into the reader too quickly, and then it just, whatever, it didn't like it. So then you have to hopefully there'll still be enough blood and you can get another reading. But it's pretty easy. Once you guys do it a couple times, you won't be worried about it at all. But does anyone have any questions yet about anything that we covered? Okay. Anybody who's available, I'll see you tomorrow at noon, and there'll be other opportunities. You can always email me too. We can set up a, a time too if you want. If you can't make that one and you want to set up another time, you can always reach out to me through email. Have a great afternoon, you guys.